Welcome to the NASPGHAN Foundation CME webinar on eosinophilic esophagitis diagnosis and management. Next. Our program today is sponsored by NASPGHAN Foundation in collaboration with the American Academy of Pediatrics Districts 2 and 3, as well as Chapter 4 and the International Gastrointestinal Esophageal Researchers. Thanks to NASPGHAN for providing the accreditation for the program, and to Abbott Nutrition, which provided support for the program. A few quick instructions. There are a number of interactive areas between the main webinar window. Please scroll down to see them. There is an area where you can comment or ask questions. Please submit your questions at any time. No need to wait until the end. At the conclusion of the presentation, we will answer as many questions as time allows. Below this area are 4 participant polls. Please don't respond to them until prompted, as we will present each poll question during the program. At the bottom of the web page is a link that allows you to download the full slide set, and also at the bottom of the page is an important link to receive CME credit. Next. I'd like to introduce the faculty. I am Chris Leocoris, a pediatric gastroenterologist from Children's Hospital in Philadelphia. Jonathan Spergel is a pediatric allergist from CHOP, and Michelle Schucker is a registered dietitian also from CHOP. Next. The objectives of the program are to define eosinophilic esophagitis and present the updated 2011 diagnostic guidelines, to understand the epidemiology, pathophysiology, and genetics of EoE, to identify the clinical symptoms, allergic manifestations, and endoscopic and histologic features of EoE, to list and define the treatments of EoE, which include dietary restriction, pharmacologic therapy, and rarely esophageal dilation in pediatrics, and to understand how to manage patients with EoE, and to provide information regarding ongoing and future research on EoE. Next. The next few slides will provide some background for those unfamiliar with eosinophilic esophagitis, or EoE for short. Next. Prior to the 1990s, the literature contained only rare reports of patients who had significant isolated esophageal eosinophilia. In the early 1990s, Atwood and Strauman reported an increased number of these patients, and in 1995, Kelly and Sampson suggested that EoE should be considered as a distinct entity. Initially, it was unclear if EoE was part of the spectrum of other eosinophilic gastrointestinal diseases, but as the number of cases dramatically increased, it became apparent that EoE was a new disease process related to the ingestion of food antigens. Next. In 1995, a study from Johns Hopkins revealed that patients previously thought to have reflux esophagitis instead demonstrated resolution of symptoms and resolution of tissue inflammation after the withdrawal of foods and the use of a strict amino acid-based formula. Briefly, 10 patients with refractory reflux symptoms and esophageal eosinophilia who had failed aggressive acid suppression therapy, 6 of whom also failed anti-reflux surgery, instead were placed on almost a complete dietary restriction and the strict use of an amino acid-based formula. Next. After 3 weeks, symptom resolution occurred in 8 patients with a near complete response in the other 2. After 6 weeks, a repeat esophageal biopsy was obtained and demonstrated normal esophageal tissue in 8 patients and a dramatic improvement in the other 2. Foods were then reintroduced, and both clinical symptoms and the tissue eosinophilia recurred. The authors concluded that EoE was a type of allergic disease that responded to food elimination. Next. Initially, EoE was appreciated in the northeastern part of the United States and in Switzerland. Between 1995 and 2013, EoE gradually has been recognized and reported throughout the entire world. The map that you see represents the locations of reported EoE literature and patients in 2013. Next. For the next few minutes, I want to provide everybody with the definition of EoE. If you learn nothing else tonight, it's important that you understand the definition of EoE, which is often confused with other disorders that cause esophageal eosinophilia. Next. However, before my definition is presented, we would like to see how you currently define EoE. I will read a poll question to you. As I am reading, please remember to select your answer by scrolling down on your screen. The answer will be provided a little later in the talk. So the poll question is, the definition of eosinophilic esophagitis includes all of the following except A, clinical symptoms that may include dysphagia, vomiting, abdominal pain, or heartburn. B, esophageal eosinophilia with greater than 15 eosinophils in at least 1 biopsy. C, normal biopsies of the gastric antrum and duodenum. D, a patient with 75 esophageal eosinophils per high-powered field that completely resolves with the use of proton pump inhibitors. Or E, eosinophilic esophagitis is a clinico-pathologic diagnosis. Again, we'll come back to this in a little while. Next. As I previously mentioned, esophageal eosinophilia can be caused by a variety of diseases listed on your screen. The terms esophageal eosinophilia and eosinophilic esophagitis are not interchangeable. EoE is a specific disease that causes esophageal eosinophilia. In order to make the diagnosis, it's important that the other diseases are excluded. In the list, the most common causes of esophageal eosinophilia are highlighted and include EoE, gastroesophageal reflux, and PPI-responsive esophageal eosinophilia. Next. Because of the increased interest, increased incidence, and possible confusion with regard to the diagnosis of EoE, 2 consensus reports have been published over the past 7 years. In 2011, a panel of 33 pediatric and adult physicians from a variety of subspecialties established a conceptual definition that states, eosinophilic esophagitis represents a chronic immune or antigen-mediated esophageal disease characterized clinically by symptoms related to esophageal dysfunction and histologically by eosinophil predominant inflammation, and also that pediatric and adult EoE are likely the same disease. Next. More precisely, the guideline states that EoE is a clinico-pathologic disease and that there are no pathognomonic features that can be used to diagnose EoE. Clinically, EoE is characterized by esophageal dysfunction and the presence of 1 or more esophageal biopsies demonstrating greater than 15 eosinophils in at least 1 high-power microscopic field. The disease is isolated to the esophagus, and other causes of esophageal eosinophilia must be excluded. A number of patients may present with clinical and histologic features supporting the diagnosis of EoE, but who completely instead respond to PPI acid suppression. These patients have either GERD or PPI-responsive esophageal eosinophilia, not EoE. Next. The answer to, this is a slide showing the first poll question, and the answer to the first poll question is D. It's important to remember that a significant isolated esophageal eosinophilia alone is not enough to make the diagnosis. If a PPI is given, which should be given according to the guidelines, and a response occurs, the patient does not have EoE. Next. I will now briefly discuss the epidemiology of EoE. Next. Several studies have been conducted attempting to identify the incidence and prevalence of EoE. The study that you see on your screen was performed by Cincinnati Children's Hospital over a 4-year period in the early 2000s. It reports that the incidence of EoE is approximately 1 in 10,000 people. The increasing prevalence suggests that EoE is a chronic disease. Since then, several other studies have been performed and suggested that the incidence of EoE may actually be greater, closer to 1 in 5,000 people. Next. This graph represents the prevalence of EoE in children and adults upon review of multiple studies over the past 10 years. Notice that the disease occurs twice as often in males and that the findings are similar for both children and adults. Next. I'm now going to briefly discuss the pathophysiology of EoE. Next. Currently, it's believed that EoE is caused by the ingestion of food allergens, which trigger an immune-mediated response releasing inflammatory mediators such as interleukins, chemokines, and eotaxin, which in turn attracts eosinophils to the esophageal mucosa, causing histologic abnormalities and clinical esophageal dysfunction. In addition, deeper layers of the esophagus are involved, and fibrosis can also develop in those deeper layers. Next. Although esophageal eosinophils are the predominant inflammatory cell types seen histologically, other inflammatory cells such as Th2 cells, mast cells, and basophils are also increased. It's important to remember that EoE is not related to the typical IgE-mediated food allergy with symptoms occurring minutes after an allergic food is ingested, but instead EoE is caused by a delayed cell-mediated allergic response, and so it's often very difficult for a patient who has EoE to be able to recognize which ingested food is causing the disease. Next. Genetics are also thought to play a primary role in many patients diagnosed with EoE. Next. Initial work performed by Cincinnati Children's Hospital in the 2000s discovered that gene chip analysis of esophageal mucosal tissue in patients with EoE was different than people who had a normal esophagus, and even different than patients who had esophageal inflammation from reflux disease. Subsequently, a collaboration between Children's Hospital Philadelphia and Cincinnati Children's identified a gene locus at chromosome 5q22 involving the TSLP gene in many patients with EoE. Next. The clinical symptoms of EoE can be quite variable. While most subspecialists recognize the various clinical presentations, it's important for the primary care physician to also be able to recognize patients with possible EoE so that they can be properly referred to the subspecialist and be evaluated. Next. Clinically, EoE occurs more often in males and has an increased incidence in siblings and other family members. EoE also commonly occurs in conjunction with other allergic or atopic disorders such as allergic rhinitis, asthma, and eczema, and is a chronic disorder in both children and adults. Sometimes IgE-mediated food allergies also exist. Next. Children with EoE often present with clinical symptoms similar to those seen in patients with reflux disease. Patients may complain of epigastric abdominal pain, heartburn, or chest pain, often related to swallowing or just after eating. Although some of these children may seem to initially respond to acid suppression therapy, either they do not respond completely or they cannot be weaned from the medication without symptom recurrence. These patients are the ones that primary care physicians should think about referring to GI for further evaluation. Next. Younger children often present with regurgitation or vomiting, again similar to what's seen in many children who have reflux disease. The vomiting and regurgitation may occur daily or may be intermittent, is often chronic, and can occur any time throughout the day. Patients with chronic unexplained vomiting or regurgitation should also be referred to a GI specialist for evaluation. Next. The symptom that's more specific but not pathognomonic for EoE in children and more commonly seen in adults is dysphagia. Older children can often precisely describe their difficulty swallowing, while younger children present instead with choking, gagging, or food refusal when they eat. Food impaction may also occur even without distinct esophageal anatomic abnormalities. Food impactions in these cases are thought to occur secondarily to poor esophageal motility due to esophageal mucosal inflammation. Next. This chart, developed by Noel et al., suggests that younger children more often have symptoms related to reflux, while older children and adults often present with dysphagia or food impaction. This may suggest that if EoE is left untreated, esophageal fibrosis worsens. Next. So what diagnostic studies should be considered in these patients? Next. Often contrast studies, such as the barium swallow or upper GI series, are useful in patients who present with dysphagia or chronic vomiting. This photo that I show you demonstrates esophageal rings or trachealization of the esophagus, which is caused by esophageal fibrosis and edema. Although helpful in determining anatomic abnormalities and the possibility of having EoE, this finding is not pathognomonic for EoE. Next. This photo is somewhat different. It shows a small caliber esophagus. While it may look normal to most people initially, the esophagus in this photo is actually 1/4 the diameter of a normal esophagus, which is caused by severe mucosal edema and fibrosis. Interestingly, both of these findings in these upper GI studies are often reversible after proper treatment is initiated. Next. As I mentioned before, endoscopy with biopsy is absolutely necessary to help make the diagnosis of EoE. Next. Esophageal furrowing, as shown in this picture, sometimes is described as railroad tracks, is frequently seen and caused by mucosal inflammation. Next. Sometimes the endoscopist instead sees white plaques that are visualized. Initially, when the disease first was appreciated, these white plaques were thought to be a fungal infection, but histologically, these white plaques actually represent eosinophilic mucosal microabscesses. Next. Esophageal rings or trachealization, like what was seen on the upper GI study that I previously showed you, represents tissue fibrosis in conjunction with mucosal inflammation. Next. Sometimes the esophageal lumen is so narrowed and inflamed that the mere insertion of the endoscope may cause a mucosal laceration. Interestingly, 25% of patients can have a visually normal-looking esophagus, so biopsies are needed to be performed in every patient, no matter what you see, even if the tissue appears normal. Next. Regarding histology, this is a photo of the classic esophageal histology in EoE. You can see a large number of reddish-orange cells, which are due to granules in the eosinophil. Other features such as basal cell hyperplasia and eosinophilic abscesses are sometimes seen. The pathologist should describe these findings in detail, but also he or she needs to report the number of eosinophils in the most densely packed, high-powered field, so that we have an accurate idea of how significant or involved the eosinophil distribution is. Next, because the esophageal eosinophilia is typically patchy, multiple esophageal biopsies should be taken from both the distal and proximal esophagus. This slide demonstrates the patchy nature of the disease. The top specimen shows a large number of eosinophils, while the bottom specimen, collected only 2 centimeters away from the top specimen, is completely normal. Again, multiple biopsies are necessary throughout the esophagus. Next. So the next poll question is this. Which of the following is not an accepted therapy for eosinophilic esophagitis? A, topical swallowed steroids. B, dietary restriction. C, proton pump inhibitors. D, systemic steroids. Or E, esophageal dilation. And again, we'll come back to this in a little while. Next. I will again discuss why the use of PPIs are important in patients with EoE. Next. PPIs have 2 important uses in these patients. First, they are used to exclude diseases like GERD and PPI-responsive esophageal eosinophilia. Second, as I mentioned previously, esophageal mucosal diseases often cause secondary reflux disease. But remember, if EoE is present, PPIs will not treat the underlying disease process. Next. What are the possible other pharmacologic therapies that are useful in patients with EoE? Next. After EoE was identified in 1995, I actually conducted a study treating 20 EoE patients with oral systemic methylprednisolone. My theory was, similar to other GI inflammatory disorders like Crohn's disease, that corticosteroids would suppress mucosal inflammation. All 20 of these patients rapidly responded to high-dose steroid therapy within 4 weeks, and they had complete clinical and histologic resolution. However, all 20 also had recurrence of the disease when the steroids were withdrawn. Because of the potential side effects using systemic steroids, they were not really an effective long-term option for patients with EoE. Next. Shortly thereafter, Fabian introduced the idea of using aerosolized fluticasone, like the spray that is used for asthma patients, but instead as a topical swallowed steroid. Patients with EoE swallowed the fluticasone spray twice daily and demonstrated both a clinical and histologic improvement with minimal side effects. The most notable side effect was the occurrence of Candida esophagitis. Next. Over the past 15 years, a number of studies have confirmed these initial results. The graph that you see on the screen depicts 4 studies that used various doses of swallowed topical steroids, ranging anywhere from 880 micrograms a day to 1,760 micrograms, again, a day, but divided into 2 doses. Every study that you see demonstrated a significant decrease in esophageal eosinophilia. The medication may not have worked in every patient, but when it did work, it was a significant result, and it worked in close to 80 to 90% of patients. Next. More recently, because of the difficulty in having children spray and adequately swallow an aerosolized preparation, a viscous form or solution utilizing budesonide was developed. Esophagus reported an 80 to 85% response rate similar to or better than what was seen using sprayed topical swallowed steroids. Currently, topical swallowed steroids represent the only accepted pharmacologic treatment for EoE. However, remember that EoE is a chronic disease and that these medications are typically needed long-term. Next. So in summary, regarding corticosteroids, systemic and topical corticosteroids effectively resolve the acute clinico-pathologic features of EoE. When discontinued, the disease generally recurs. Systemic corticosteroids, although not used long-term, can be utilized in emerging cases such as dysphagia requiring hospitalization, dehydration due to swallowing difficulties, and severe failure to thrive. Topical corticosteroids are effective in inducing a remission of EoE when utilized in high doses in both pediatric and adults. The incidence of long-term side effects with this formulation has not formally been studied, but currently it appears to be well tolerated and used by many physicians. So topical steroids are certainly used for maintenance of EoE, but the studies are still ongoing for long-term effects. Next. So the answer to the second poll question is C, proton pump inhibitors. And again, the reason is that proton pump inhibitors alone aren't a therapy for EoE. They can be used to treat symptoms related to EoE in terms of secondary reflux, but the other answers you see on the slide are actually true treatments for EoE that are used by physicians and subspecialists. Next. Poll question 3 is in this slide, and the question is, of the following dietary therapies, which is not an accepted therapy for EoE? A restricted diet based on the removal of the most likely 6 foods causing the disease. B, the strict use of an amino acid-based formula. C, a restricted diet simply based on a patient's symptoms. Or D, a restricted diet based on skin prick and Atopy patch test allergy testing. Next. So now I'm going to turn it over to our allergist, Dr. Spergel, who's going to discuss dietary treatment and other allergic features of EoE. Jonathan?
Thanks, Chris. So, Chris, I'll be and welcome to everyone. I'll be talking now about how roles of diet in EoE and how to pick foods and why we think food works. So we'll be going on to the next slide. There are 3 basic ways we can think about dietary therapy. One is amino acid formula, which Chris had initially mentioned, but that was done by Kevin Kelly and Hugh Sampson. Other ways you can pick individual foods, and there's 2 basic ways to pick individual foods: an empiric elimination, just sort of more or less by guessing, or targeted therapy, which is by testing. And we'll go over each option and the pros and cons of each different option. Next slide. And the first one we'll be talking about is amino acid formula. At our institution, which Chris published about almost 10 years ago, we looked at about 170 patients who had amino acid formulas. Most of them at the time actually needed NG tubes. Our success now is a little better about that, as formulas have tasted a little bit better. We had about 160 patients who completed the therapy, and we looked at the symptoms in biopsy, and that's 4 to 6 weeks later. And as you can see, almost everyone had complete resolution of their esophageal eosinophilia, complete resolution of their symptoms, as well as their whether it's GERD or dysphagia. In our next slide, you can see how well the inflammation went away. In the panel on the left, you see all the eosinophils before we did the therapy, and on the right, the normal-looking esophagus with complete elimination of the eosinophils. And our next slide sort of summarizes the true advantages of potentially of an elemental diet. You can have complete resolution in about 90+% of the patients by using elemental diet. You can allow sort of an easy introduction, and it works quickly, and it really allows complete resolution. The last point, it's a little more controversial, whether it can lead to tolerance or not. We've had a few patients who've had tolerance, and it's really unclear whether it was using amino acid formula, or was it elimination of those foods and waiting over time. So it's unclear which is the right way, which is whether that truly makes a difference or not. But there are some disadvantages, which we'll talk about at the end, and we summarize at the end of the pluses and minuses of food allergy. The second way to eliminate foods is an empirical elimination. This is a diet that's been really founded by Amir Kalawagar at Northwestern, the so-called 6-food elimination diet. In his initial study, he did a retrospective review where he gave 35 patients the so-called 6-food elimination diet, and 25 patients got an amino acid formula. The 6-food diet at that time was milk, soy, wheat, egg, peanuts, all tree nuts, fish, and shellfish. In 75% of the patients, the the patients on the 6-food elimination diet, they had an improvement in symptoms and a decrease in esophageal eosinophilia. However, the patients on amino acid formula had a 90% response, similar to what we saw, and had a further reduction. So the patients on the restricted diet went down to around 10, and the people on the amino acid diet went around to 1. So both worked, but amino acid probably worked a little bit better. So just to summarize some of the advantages of the empiric diet, it's easy. You don't need to test. There have been several studies now in the literature, too, just coming out on various forms of 6 foods, 4 foods, along those lines. Some disadvantages are it may eliminate too many foods, it may leave some foods that are not necessary, and still a 6 diet's not an easy diet. Easier than an elemental diet, but still not an easy diet. The third option is sort of removing foods by testing, which is allergy testing, as we can see in the next slide. And on the next slide, sort of summarize the main different ways you can do allergy testing. One is by prick skin test. One is by specific IgE, also called RAS testing. The other is by ATP patch testing. And there's several other tests out there are sort of very controversial and really haven't been tested. And these include hair analysis, IgG testing, cytotoxic testing, applied kinesia. All these tests really have never been validated and really don't seem to have any effect at all. The IgG testing, which I want to add a couple extra comments on, is probably the most commonly one used, and that's very useful in telling me what you're eating. Everyone makes IgG to foods. If you don't, you have an immune deficiency. I need to see you for that problem. But if you don't make IgG, so the higher you are to IgG to that food, either you're more tolerant to the food or you're eating it a lot. On pricks, so the next slide discusses the basic ideas of prick skin test. And this is prick skin test has been around for a century or so. It's looking for specific IgE to food. And this test is looking for basically foods that cause an immediate reaction. It works great for foods that cause anaphylaxis, like the famous peanut allergy. You put a drop of food on, you scratch with this little bifurcated needle, and you get a little red bump. This is relatively reproducible, but it's important to know whether you're doing it for prick skin test or specific IgE or the RAS testing. The predicted values vary from food to food and test to test and age by age. So you really need to know what you're doing about this. You just can't sort of order it haphazardly because you can get a fair amount of false positives and occasionally false negatives. On the next slide, you can see what a skin test looks like. The two top panels will show 2 different devices. In the bottom panel, so there's a picture of an arm, and you would actually see those big red bumps, looks like big mosquito bites. And there's actually, in about 10-15 minutes, you see those red bumps on their arm. And you're looking at the size. The red bump is the more likely you have an allergy, but it doesn't tell you how severe it is. On the next slide, talks about ATP patch testing. Now, ATP patch testing has been around for a long time, also for about 100 years. It has been originally designed for nickel allergy, so what the allergy you get when you have a belt buckle and you get a rash where a belt buckle is. And it was developed for foods back in the 1990s, originally for atopic dermatitis and eosinophilic gastrointestinal diseases. The one problem with this compared to skin tests is the reagents aren't standardized. While in skin testing, reagents are standardized, but reading is a little less standardized. The general idea, as you can see in the next slide, is that these patches are placed on the back in these little chambers, as you can see in that left-hand panel, and they're put on the back and taken and read 72 hours after the patch has been on. You leave it on for 40 hours and take it off. And you look for these red little spots. The more red spots you are, it's more likely you have a real reaction. And the idea is this is looking for a delayed hypersensitivity reaction. So on our next slide, we go over some of the results that we published about food testing in EoE. So it's important to know most of these patients are allergic, as Chris has mentioned before. Almost about 3/4 of them have some sort of other allergic disorder, whether it's asthma, allergic rhinitis, or atopic dermatitis. And interestingly, about 1/3 of them have negative skin tests, or negative to everything. But the foods that showed up are the more common foods that you see in regular food allergy: milk, soy, egg, peanuts. About 1/4 of them are negative on patch testing, and 1/4 of them are negative to both. So when we went back and actually looked at what foods we found, and consistent with what work had seen from the Rothenberg group out of Cincinnati, the Northwestern group, as well as Lucenda group out of Spain, everyone sees the same sort of foods, whether it's done when you reintroduce foods, seeing what foods cause symptoms by biopsies. Everyone's seeing the same thing. It's milk, egg, wheat, soy, then everything trickles down after that. So corn shows up, some of the legumes, as you can see, the meats, and other things come up. Most EoE patients have 4 to 5 foods. In our hands, we had about 20% of the patients who had so many food allergies, we had real trouble advancing their foods, and they really needed to be managed with a mixture of diet plus steroids or elemental formulas. The next slide goes over sort of some of the pluses and minuses of elemental diet, empirical diets, and targeted diets. This was a recent review that was published in Journal of Jackie in Practice. I mean, elemental diets probably have the highest success rate, so that's the true advantage. The disadvantage is it's often difficult to do. There's taste problems. Kids often over time have trouble with taste and adding foods back. There's texture issues, and it has a really big effect on quality of life. Empirical diets, the one advantage is you don't need testing. It's been studied in all ages. It does work, but again, it's expensive. You're probably eliminating too many foods. You probably only need to eliminate 4 foods, but not the whole 6 foods. Maybe you can get by with even 3 foods. The targeted effect, it's probably the most specific, which is an advantage. You can probably have a better chance of preserving the diet, but it's not as well standardized. It does work about the same. Both the empirical and the targeted work about in between 70-80%, similar to topical steroids. Just to summarize what we know about in dietary therapy, they all work. Amino acid works the best. 6 food and the targeted therapy both work around 70%. All these diets can lead to complete resolution of both clinical and histological findings. Studies done actually out of the Mount Sinai group have shown that dietary therapy can completely reverse the fibrosis that Chris was talking about. But it's important when you do this dietary therapy, you're really having a major factor on their diet. So it's important to talk to a registered dietitian to make sure patients are getting enough calories and micronutrients to grow. Which leads me up to our next poll question, and with the answer to the last poll question. So, of the following dietary therapies, which is not an accepted therapy for EoE? The answer was C, because patient symptoms really, unfortunately, don't correlate that well with true disease. As Chris was mentioning early on, this is sort of a delayed reaction. Well, not like when you eat a food, you have an immediate reaction like with milk and peanut. Things are much more delayed. So the other true therapies of amino acid, doing testing, or doing a restricted diet are all reasonable options to do. In my next section, we'll be talking about EoE and Atopy, talking about why as an allergist I care. So the next slide talks a little about the prevalence of EoE in prevalence of Atopy and EoE. Asthma, allergic rhinitis, and atopic dermatitis, as well as regular food allergies, are much more common. Asthma in the general population is seen anywhere from 10 to 20%, while in EoE is close to 50%. Allergic rhinitis is seen in almost 75% of the patients, while IgE-mediated food allergy in the general words are anywhere from 1 to about 5%, but seen as high as 20% in our EoE cohort. So these patients are really allergic, and so it's important they get evaluated by an allergist because they have all these other atopic issues that can really drive and change disease. And our next slide talks about an interesting but rare cohort of patients who really almost have a pollen-driven disease. This was a case report that we published over 10 years ago now of one young woman who had only EoE during the pollen season. Her EoE completely resolved in the winter and came back during the 2 pollen seasons. You can see in those dark blue areas. There have been a few other case reports like this now been published, and people also have published a few case reports of EoE being more likely diagnosed in the spring pollen season. This suggests that pollen potentially can play a role, but we know mostly it's probably driven by foods. But pollens probably play a small part. So it may add a few extra 5 to 10 to 20 EOs to a patient, so those EoE will exacerbate during pollen season and get better out of pollen season. But the primarily driving the disease is food. But some of the little fluctuations you may see may be due to pollen. And our last poll question is on the role of the dietitian. The role of the dietitian in patients with EoE can include all the following, except perform allergy testing, skin or patch testing, B, help patients and families understand how to read food labels to avoid allergic foods, C, work closely with allergists and gastroenterologists to help treat patients with EoE, D, monitor height and weight in order to outline adequate calorie intake. And now I'd like to introduce Michelle Schucker, who is a registered dietitian, who will help discuss the role of nutrition in EoE.
Thanks, Dr. Spergel. So we're going to talk a little bit about nutrition in EoE and the role of the dietitian. As we'll see on the next slide, some of these the roles are listed here. So, of course, the role of the RD is going to be the assessment of nutritional status. Luckily, many of our patients do present well-nourished. Also, the role of the dietitian is going to be the determination of dietary adequacy, to work within the dietary restrictions to provide a balanced and acceptable diet, to provide education to the patient, family, and other caregivers, including school staff, and to identify and assess for barriers to effective nutritional therapy. On the next slide, we'll just do a quick review of the components of the nutrition assessment. So first, we want to make sure that we have accurate anthropometric data. As I mentioned, luckily most of our patients do present well-nourished, and as we all know, it's going to be important to monitor these measurements over time. One crucial component is to obtain a detailed diet and symptom history. It's very, very important to know where we are starting with diet, because that's going to help tell us where we should go, or some of the best places to go once we start removing foods. The evaluation of dietary adequacy not only involves the assessment of the diet at the time of diagnosis when we're talking about removing foods, but also prior to diagnosis. Again, that goes back to the history. We want to see where we started, how adequate was this diet, and that's going to influence potentially the plan. We also want to make sure that we identify any feeding difficulties, food refusal behaviors, selective eating, etc. These behaviors are commonly seen in younger children, although sometimes in older children as well, who may have developed a quote-unquote fear of eating once their symptoms become pronounced. And these eating behaviors, especially in younger children, may not always resolve with normal biopsies, so these behaviors will need to be monitored over time. The biochemical assessment, we would obtain labs as needed, so CBC, CMP, vitamin D levels, prealbumin, zinc, iron studies, all things that you might typically find in a nutrition assessment, and all these are done on an as-needed basis. On the next slide, we want to look at some nutritional considerations, specifically dietary adequacy, when we start removing foods. So if we're just removing one food, let's say milk from someone's diet, assuming that the rest of the diet or the diet prior to diagnosis is reasonably varied, a single food hypersensitivity is managed well, as long as we can have the patient make appropriate food choices and that they are accepting of the various substitutions that are available. However, the more foods that we increase, of course, the risk of dietary inadequacy is going to increase as well. Micronutrient supplementation is often necessary the more foods we remove, and luckily there are a variety of allergen-free products available. Dietary fiber supplementation may be needed in some cases, particularly when we start removing wheat and other grains. When we're removing wheat and relying on gluten-free grains, many of these alternate grains tend to be low in fiber. Also, for some patients who have a decent part of their diet replaced by elemental formulas and whose intake of fruits and vegetables may not, or may be suboptimal, or either by restriction or patient preference, there's more fiber missing from the diet. And these elemental formulas, most of them don't contain any fiber at all. Some contain a little bit of fiber, but still additional fiber might sometimes be needed. So if we can increase fruits and vegetables, we'll suggest doing that. If need be, we can also use a commercial fiber supplement. Those with psyllium, methylcellulose, or inulin are acceptable, usually on diets, and then we will just use what's tolerated best in the patient. So looking at the next slide, when we are looking at the essentials of elimination diets, first it's important to carefully identify allergens in the diet. So this goes back to before we are going to talk about removing foods, and then once we decide which foods are going to be taken out. So we want to make sure, we want to look through the diet, make sure that the patients and families are able to identify the presence of allergens and then be able to look for them so that they can be avoided. This is where the education of the patient, family, other caregivers, including school staff, comes into play. It's going to be important to, over time, assess and monitor this situation to make sure that the diet is adhered to, and also that we are able to preserve or improve, when needed, the patient's nutritional status. And as we go along, there may or may not be a need for supplementation with elemental formula or other high-calorie supplements. And the next slide, we're going to look at the keys to success of elimination diets. So as I touched on before, reading food labels is crucial to successful avoidance of allergens. So labels should be read each time the patient or family shops for food or is preparing food. And contacting the manufacturer may sometimes be the only way to clarify the presence of certain allergens, specifically these minor allergens. So the top 8 allergens, major allergens, which include milk, wheat, egg, soy, fish, shellfish, peanuts, tree nuts, fall under the food labeling laws for inclusion on food labels. So it's mandated that those allergens appear. However, allergens that are avoided for EoE, let's say corn, for example, are not on that list, the top 8. So it's going to be very important to make sure that those labels are reviewed very, very carefully, because for ingredients like that, there is not going to be one of these contains statements that you see at the bottom of food labels. If there is any doubt that a food contains a questionable ingredient, then the food should be avoided, of course, and then education should be provided to the family about the specifics of food labeling laws. Education should also be provided regarding cross-contamination, both at home and when eating out. And families should be acquainted with resources that assist with food shopping, food preparation, restaurant eating, etc. And the Food Allergy Research and Education Group has many, many great resources which can be found at their website, foodallergy.org. Underscoring all of this, or really the biggest take-home message when educating patients and families about an elimination diet, is to emphasize what can be eaten versus what cannot be eaten. Always very important to stress that. So sometimes a total elemental diet is required, and on the next slide we'll talk about that. So when we talk about needing to do an elemental diet, that is defined by providing all of the child's nutrition by way of a 100% amino acid-based formula. There is also another product, Neocate Nutra, which makes what is best described as an elemental pudding, which is a semi-solid food that can be useful for some younger children to help preserve their feeding skills, while all other solid foods are removed. And we also have had some older kids who liked it as well, but it's a product that was added a few years back that is shown to be useful. But when we're doing an elemental diet, we want no other solid foods, almost always. Water obviously is fine to do. Certain fruit juices, this needs to be discussed on an individual basis. We sometimes allow Gatorade, and candies with very few ingredients, including sugar, corn syrup, artificial flavors, colors, may be permitted. The candies listed here are the old tried and true products that we've used throughout the years with good results, but other products with similar ingredients may also be acceptable, and again, it should be discussed on an individual basis. So an elemental diet, typically the duration of this is shorter than the average elimination diet. With an elemental diet, we usually will treat solely with the formula for about 4 to 6 weeks, then have a repeat endoscopy, versus we're doing an elemental diet, let's say removing 1, 2, 3, 4 or so foods, we'll usually have a minimum of 8 weeks on that therapy, and usually the duration is around 2 to 3 months. Obviously, there are going to be volume goals for elemental formula. If a patient is unable to take the required volume by mouth, then that's when we need to discuss tube feedings. In our total population, we have about, at this point, 14 to 15% of children who receive more than half of their nutrition from elemental formula, but only about 5% of the total population are tube fed at this time. Next slide. So elemental formulas, the flavor of those has improved dramatically, and I might add thankfully, over the years, but they taste different. So the reason they're hypoallergenic is because of the protein source, this being 100% free amino acids, but when you mess with the protein in anything, of course you're going to mess with the taste. So enhancing acceptance is certainly something that we want to work on. So the flavoring of formulas is sometimes helpful. Of course, many formulas now come in a variety of flavors, and sometimes we need to have a little DIY flavoring occurring as well. And some options would be to use flavor packets from manufacturers that provide them, using allergen-free chocolate strawberry syrup or some sugar-based drink mixes that can also be effective. These formulas are usually best served chilled. We have a few children who prefer to have them slightly warmed, but for the most part they tend to taste better, and there is therefore better acceptance when they're chilled, so they can be made into smoothies or popsicles to enhance acceptance. And because there is a distinct smell as well, taste to these formulas, they may be accepted better if we try to bypass the smelling of the formulas by using a closed cup that can be used with or without a straw. That also helps bypass some of the taste buds when you're taking it in, so it may not be as objectionable. Works for some kids, does not work for other kids, as you know, we could say that about just about anything. On the next slide, we're going to look, though, at the practical considerations when we're talking about an elemental diet. So we know that an elemental diet is very effective therapy, but there are also some downsides. The first one listed here would be the cost of the formula. Those of you who use elemental formulas in your treatment of these patients know that these formulas are very expensive. We are lucky in this area of the country that we've had some considerable success with insurance coverage, although I must say that's been a little bit more difficult lately. But when we look at what the average monthly cost can be for children of different ages who have 100% of their nutrition provided, it can be upwards of $800 a month for your average 3-year-old, and easily exceed $1,000 a month for a teenager. So that's something to keep in mind. Other practical considerations when we're talking about treatment overall is that for the presence of food refusal behaviors. So when we see these present in younger children, we can only assume that the children have developed an aversion toward eating as a result of the inflammation they've had for however long. But what we also tend to see is that these food refusal behaviors or selective eating persist even after allergens are removed and biopsies are normalized. And this is probably in response to this being a learned behavior. But usually we will end up referring these children to a feeding specialist, even when the biopsies normalize. Another consideration is the access to allergen-free products, and this, although much more available, these products are much more available throughout the country, access to these products does remain limited in some areas, and this may require a modification of the treatment plan. So sometimes we might need to look at a more conservative approach with fewer diet restrictions, or sometimes consider sooner rather than later the use of swallowed steroids if the access to these products is so limited that it's going to affect the ability to adhere to the diet. On the next slide, we want to look at the importance of family support. So as we mentioned earlier, we're going to want to be working with schools to educate staff and minimize the risk of exposure to known allergens. This is where Food Allergy Research and Education Group comes in. Lots of resources available on their website. Usually what we want to do is make sure that at school there are provided safe, non-perishable foods for snack time, for parties. For those with IgE-mediated allergies, we want to make sure that there's an emergency kit with Epi available at all times. And as I mentioned earlier, on the FAIR website are other resources for eating out in restaurants or attending camps, etc. In the office, when we're providing educational materials, we want to make sure that they are thorough, that they are updated, and of course easily understood, and as many copies as needed provided to as many family members or caregivers as needed. It's also crucial for there to be communication amongst all members of the clinical team, and of course to communicate well with the family. This is so important in making sure that we have the best possible clinical plan or treatment plan developed, and so that we can appropriately monitor response to therapy. We also want to make sure to provide information to empower these patients and their families, and to encourage self-education. So we want to provide these tools, but we want to educate them so that then they are then able to go out and find these foods, prepare safe foods for their family. So we want to practice the art, as it were, of delivering the science. And at this point, I'll conclude by sharing the answer of poll question number 4, which was A. So the dietitian is going to do all of the following except perform allergy testing. And at this point, I'll pass the program back to Dr. Leah Corris, who will discuss biologic treatment.
Thank you, Michelle. So on the biologic treatment slide, as I previously mentioned, corticosteroids are the only accepted pharmacologic therapy for EoE. However, biologic therapy may provide some future alternatives. Next, one particular therapy is anti-interleukin 5. IL-5 is the predominant cytokine that mediates eosinophil function and activation. Because eosinophils are the most involved cell type in EoE, the disease process may be significantly impeded if the eosinophil production, activation, and recruitment is inhibited by things like anti-IL-5. Next. This slide shows a graph and represents an early study which demonstrates the use of anti-IL-5 on esophageal eosinophils in patients with esophageal eosinophilia. Anti-IL-5 was given by IV infusion once a month in these patients, and after 3 months, repeat biopsy showed a significant decrease in esophageal eosinophilia. In addition to EoE, anti-IL-5 has also been thought to possibly treat types of asthma, nasal polyposis, and eczema. Next. Currently, 2 studies are in progress or in process using mepolizumab and rislizumab, 2 anti-IL-5 molecules. Hopefully within the next year, these medications will be approved. Now, once approved, they're certainly not going to be used for everybody that has EoE, but instead will benefit those patients with severe disease, patients with failure to thrive or severe strictures, and also include those who have significant asthma or atopic dermatitis or eczema. Next. So just for 2 minutes, I'm going to discuss the future of EoE. Next. Studies are certainly underway evaluating different pharmacologic options and different steroid formulations. Other biologic targets, including IL-13 and eotaxin, are being conducted and being considered, as well as other therapies such as prostaglandin inhibitors or co-therapy using PPIs. Now, everybody wants to know what PPI-responsive esophageal eosinophilia is, and there are some investigators who believe that PPIs not only have an acid suppression effect, but also have an anti-inflammatory effect. Next. Currently, endoscopy with biopsy is required to make the diagnosis of EoE and to follow the progression or the disease response. The hope is in the future to develop non-invasive esophageal or serum biomarkers to replace the need for frequent endoscopies. Another alternative may be the use of an esophageal string test, which unwinds after the patient swallows a small capsule. The string is then kept in place for a period of time, and when removed, it can be evaluated for esophageal secretions and cells. Next, I just finally want to touch on possible advocacy groups for patients. Next, As seen on this slide, several advocacy groups exist to help patients, families, and physicians with information ranging from clinical symptoms to insurance issues to a possible available research related to EoE. Next. So in conclusion, we gave you a lot of information, but just so you know that EoE is certainly now considered a clinico-pathologic disorder diagnosed mainly by clinicians. EoE can occur at any age. Pediatric and adult EoE are likely the same disease. The incidence and prevalence continue to rise. It's important that you also realize and make the distinction between eosinophilic esophagitis, esophageal eosinophilia, and PPI responsive esophageal eosinophilia. And certainly stay tuned. There's so many people involved and interested in EoE that we expect more changes and ideas to occur. And with that, hopefully the guidelines will adapt every few years. So now, so thank you again for attending. Now we're going to answer as many of your questions as possible. And please, if you would like, continue to enter questions as we go along. And again, this will be for the entire panel. So when I put a question up, and if I start to answer, or if you want to answer, Jonathan or Michelle, please do. So I think one of the first questions I want to address is something that we didn't really talk about in terms of dosing of steroids. We gave you ideas about the dose of swallowed fluticasone that ranged anywhere from 440 micrograms a day to 1,760 micrograms a day, usually split in a couple doses. But when we didn't really talk about budesonide, which is one of the most commonly used medications these days, and one that we typically use in Philadelphia. And in general, the dose that we use in children under 10 is 0.5 milligrams twice a day. In children over 10 years of age, 1 milligram twice a day. And then hopefully over time, after we evaluate the response, we may attempt to wean this medication to as low a dose as possible. One of the questions also was how often do we do endoscopy? And again, I think in general, and Jonathan, you can comment too if you want, we typically utilize endoscopy not only for the initial diagnosis, but really for response to therapy and any time we change therapy. As we talked about before, it's not easy for patients to always tell us how they feel symptomatically, so we use esophageal biopsies to be sure that we know what's going on histologically. I'm not sure if Jonathan, you have anything.
Yeah, so I agree. So we typically, in terms of time, once we do a change, whether it's medication, increasing a dose of topical steroids or decreasing a dose of topical steroids, or adding a food or removing a food, we typically wait anywhere from 2 to 3 months. You can see changes as soon as 1 month, but we typically wait a little bit longer to make sure we have a good endpoint, that our endpoint's probably everything is we're seeing what a true effect is on the medication. In terms of doses, Chris gave you the starting doses, but we'll go up and down. I mean, we've gone up as high as Chris was talking 1 milligram twice a day. We've gone as high as 2 milligrams twice a day of budesonide. And most of our patients on Flovent don't do well on the 44, but need either 110, 2 puffs twice a day, or 220, 2 puffs twice a day. But we've gone up as high as 4 puffs twice a day. So the dosing really is sort of patient-dependent. And it's really important when you use the topical steroids that they have good technique. A lot of times people tell them you should, after taking, you should swish and spit out or drink afterwards. But the idea is not to do that. When you take it, you take the medication and you don't eat or drink for 30 minutes afterwards, so it coats the esophagus and you get the maximal topical effect as possible.
One of the things we didn't mention because of the time duration of the talk was other medications that had been tried in the past. People have attempted to use cromolyn sodium, mast cell inhibitor, or Singulair, the Montelukast, to treat those types of problems. And really, cromolyn hasn't had any effect at all in past studies. And Singulair or medications like that really have at times demonstrated some clinical response in patients, but absolutely have no histological response. So we would prefer and rather use a medication that's going to affect both clinical symptoms and histologic abnormalities. So really, corticosteroids at this point are the only medication that is effective and is typically utilized in patients.
There were several questions on when do we biopsy, how often do we biopsy for clinical, when someone's in clinical remission, and when do we stop steroids. So I'm sort of going to try to group them together, then I'll see if Chris wants to add some stuff too. In terms of remission, if someone is on, say, a therapy or a diet that they're happy with, we often won't biopsy unless they come symptomatic, or wait maybe 1 to 2 years to make sure things are going okay. So if someone's on a diet, say if they're taking milk out alone, they're doing great, we will leave them on that diet for a couple years and then say, hey, you're doing great, let's see what's going on. So in terms of the endpoints, we typically will go by histological endpoints. We'll actually go down and make sure biopsy is okay. Chris, do you want anything on?
Well, the only thing I want to mention is, at the very end of my talk, I talked about the future, and again, as more and more is known about EoE, we kind of shift the way we think about it. I think Jonathan and I both practice differently now than we did 15 years ago, and over the last 5 or 10 years, people have been very interested and understand that things like the 6-food elimination diet work very well. But actually, people now are thinking about starting with 2 or 3 food elimination diets, because maybe we can get lucky and identify, since we now know a lot more about what foods are the most likely culprits, might be able to save patients a lot of trouble and time by starting out with more limited diets. Again, the problem is none of this is we don't have a test that's perfect, and so this all requires a little bit of guesswork. But the idea basically is once you have things under control, both clinically and histologically, you can adapt by either adding back foods, or if you're on medication, weaning the dose of medication. But you always at some point have to be sure that both clinical symptoms and histology has responded. As Jonathan mentioned, once patients are happy, once patients and the physicians are happy where they are, and they really would rather stay put and not change anything, we can go for a long period of time without doing anything else until they want to change. We often have children or young teenagers who are on significant dietary restriction, but as they get older, they're going to go to college, they go to high school, and they would rather eat other foods, and so sometimes they shift from diet to steroid use. And alternatively, sometimes we have older people who have been on corticosteroids for a long period of time and are tired of taking medicine, who'd rather, again, approach the dietary therapy. So we can shift a little bit, and every time you shift, you really need to identify both clinically and histologically what's going on in the response to your therapy. Except for when patients clinically feel completely well and there's still some evidence of tissue eosinophilia. That's one of the hardest questions. There's about 3 or 4 questions that people ask today about that, and that's a difficult problem, because the obvious answer is we don't know 100% what it means to be clinically asymptomatic but still have ongoing tissue inflammation. And I'm going to also relate that to other diseases like Crohn's disease that a lot of the GI people take care of, or asthma that Jonathan and other allergists take care of. We're now realizing more and more that patients appear to be clinically improved, but histologically, even in those diseases, they can have significant tissue inflammation. And I think more and more the concern or thought is we may need to treat those underlying inflammatory processes. But at this point, I think the jury is still out. So in general, I think the way Jonathan and I approach EoE is if we have a patient who has severe tissue eosinophilia, 50, 60, 70 eosinophils per high-powered field, and we give a therapy, and clinically they're doing great, and we go back and we see 20 or 15 or 18 eosinophils. We may say, okay, that's okay, we can live with that for a little while and see what happens. Alternatively, if they have still 100 or 80 eosinophils, we probably would still be more aggressive in treating them. So a little bit depends on the response and how the tissue eosinophilia changes with your treatment. We don't know. I think in the old days, 15 years ago, we all wanted the inflammation to go to 0, like what a normal esophagus should appear. But I think right now we are able to accept a few eosinophils as long as they're clinically doing well. Now, in 2 or 3 years, if the medical world, again, not just in this disease but other diseases, realize that ongoing tissue inflammation, to treat that is important, we may change our mind and say you have to be even more aggressive. I don't know if, Jonathan, you have anything to add about that?
Yeah. I mean, I really go back and forth on this issue because most diseases, when you think of asthma, heart disease, diabetes, inflammation, Crohn's disease, inflammation is bad in almost every disease. The question is, how much inflammation do we need to go to 10, 15, 20? How low do we go? And I think it's going to be the big question. It may take years to answer that question. But I do think if we leave inflammation, even someone asymptomatic, it's a problem. Because we know from every other disease, inflammation is a bad thing. There were a couple questions on aeroallergens.
Yes.
The one is, what's the role on aeroallergens? So just to answer that quickly, so just pure aeroallergen-driven disease in pediatric EoE is really rare. But maybe 10 to 25% of the patients, you'll see that they'll have exacerbations during pollen season. Typically, we treat them with just standard medicines for seasonal allergies. A few patients will decide not actually during pollen season because they flare so much. Interestingly, the new thing that's out in the allergy world, sublingual immunotherapy, there have been at least 3 case reports now of inducing EoE with that. So when you swallow pollens, whether it's food or swallowing pollens for immunotherapy, you can actually induce EoE. It's not surprising you're seeing the same thing. No one's looked at subcutaneous immunotherapy or standard immunotherapy for EoE. For the pollen side, has not been studied at all. There's no reports in the literature one way or the other. So the question is, do what we test? We treat the pollen allergy. If you need to test them for environmental allergies, it definitely does make sense.
Jonathan, let's answer the question about how do we decide what therapy to use.
Okay. So that is what therapy to use. This is the art of medicine. I'll present all options to the families. I'll say, hey, here are the 3 options. You can do dilatation, which we don't recommend. Actually, there's 4 options. We can do nothing. You're here, you're symptomatic, we don't really recommend that. Third option is dilatation. Don't recommend. It's going to come back, and there's risk of perforations. There's steroids and diet. And we'll go over each, sort of say, steroids have this, pros and cons. Diets have this, pros and cons. In general, the small kids all do diet. The teenagers all do topical steroids, just for personal reasons. But we present all ones. I prefer to do diet. I think Chris prefers to do diet because I'd rather take out what's causing disease. What's that balance of quality of life, patient compliance, and clinical effectiveness?
Yeah, I think when Jonathan says all little kids do diet and all big kids do pharmacological, we're actually surprised sometimes when some bigger kids want to do diet, and they do, and some little kids want to do steroid. Basically, what I think he's saying is that we try to tell once we diagnose EoE, and that's, again, the important thing, make sure you have the right diagnosis. Once we diagnose it, we present every option to people. When I go around and talk in lots of places, all the options aren't presented, and so most people use medical therapy, pharmacotherapy, and think that people will do diet. But you'd be surprised if you present people with all the information. Some people, even older people, are going to decide to use diet. There are studies out in Chicago now that diets work perfectly fine and the same in adults as they do in kids, and there are some people using dietary therapy, acid-based formulas as an adult. So I think your best bet is to present all the information, and then together, you as a group, the physician and the family, decide what the best therapy is. And not that you have to stick with that. You can also change your mind over time. And so we love diet only because that's the cause of the disease. We'd rather treat the disease if we could, but we certainly utilize almost every therapy, and even have to do dilation if we have irreversible fibrosis in patients.
So Michelle, only a question from Michelle here. After eliminating several foods, how do you decide which foods to introduce first?
So the answer to that is the same answer that we give to almost every question, which is it depends. But if we are eliminating, and it depends usually on, and this is assuming that we're just doing an elimination diet, not an elemental diet, but if we're removing let's say, milk and wheat and an egg, for example, first we want to really, it depends on the exposure to the food prior to diagnosis. That's one very important thing. And then also looking at whether or not how risky these foods are. Are they, high risk foods for EoE? So milk we see as the most common food to cause this. So if milk is one of several foods that comes out, we'll usually try to leave that, the reintroduction of that until last and just work our way up. Technically, it doesn't matter which one we put back in, but we try to, we really want success for everybody, so we try to introduce the foods in a way that will maximize the chances of seeing a normal biopsy, even though we don't know for sure. And there are, again, this all goes back to what Dr. Lee Corus was talking about presenting, having a thorough discussion about the risks involved. And, there are families who will certainly opt to put back milk because that's what they miss the most. And with an understanding of the risk of seeing an abnormal biopsy, they'll go ahead and do it. But that's generally the way that we will follow the reintroduction.
Jonathan and Michelle, thanks again for those answers. We have to close the webinar now. I want to thank the faculty for their excellent presentations, to thank NASPGHAN and the NASPGHAN Foundation for their sponsorship, to thank the American Academy of Pediatrics and Tigers for their collaboration, and to thank Abbott Nutrition for providing support for this program. And certainly thanks to everyone who participated and attended the program and for asking many thought-provoking questions. Thanks again.